Okay, good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Your tuning in today means a lot to me, so thank you. I appreciate that. I know you are all busy people. You have lives. I have a life. We all have lives. We're busy. We're doing things, and the fact that you're tuning in means a lot to me. So thank you for being here. If you like what you hear, write a nice comment somewhere. Tell a friend, tell a relative, because we're building an audience, and we are building an audience. Actually, I just heard yesterday, that we are in the top 3% of all podcasts in the world, I guess. I don't know which category I think it's in the world. So I'm very, very proud to share that with you guys. So anyway, we want to be number one. Look out, Joe Rogan, here we come. So anyway, but I like people to be tuning in because the people I bring in front of you on a weekly basis are amazing people. And today it's a pleasure to welcome a friend of mine. His name is Dr. Paul Austin. He lives in the Santa Monica area. He works in the Santa Monica area. He is an orthodontist, and Paul, thank you for taking time out of your schedule to join us today on the Hamilton Review.
Well, thank you for having me.
It's a pleasure. So, Paul, I always begin my shows by asking my guests to just kind of sit back and tell us a little bit about your life, who you are, where you're from, the stages of your life that you went through that brought you where you are today. So I'm going to turn the microphone over to Dr. Paul Austin. Paul, you're up.
All right. Well, thank you again. And so I grew up in Southern California, a little town, Del Mar. You might have heard of it, where the turf meets the surf at Del Mar. And, had a pretty typical childhood, but growing up on the beach, surfing and boogie boarding, playing volleyball, those kind of things. My life really changed when I went off to college. I went to UCLA for my undergrad, and I did actually a medical mission while I was down there. It was I wasn't on the medical side. We were part of the building team. So we went down to Tijuana, to these dumps down in Tijuana where people were living in refuse, and we were building homes for them. And I was sort of the head person helping build these homes for all these people. And I think it was through Brentwood Presbyterian Church at the time. They were the ones who sponsored us.
Yeah.
And there was a lot of, it was just a great group of people, and it had a profound effect on me. And it kind of steered me in a different direction of my life in a couple ways. One, in that I knew that I wanted to do something that helped people, that had something to do, working with people.
Yeah.
And it was like also sort of my first experience of exposing myself to God, really. I didn't have that upbringing, so it was a kind of a big deal for me, that whole experience. And then I would say what kind of followed shortly after that was an opportunity to work at a summer camp. I was sort of thinking about what job I was going to do. This, again, it's like God working in weird ways. I was just at a table. It's like the last day of school. And I happened to mention to a group of people I didn't even know that well, that I was like thinking about what I was going to do for the summer, and was hadn't really come up with anything. And this girl that was at the table said, "Well, I just got a job at this amazing camp. You would be great. You'd be a great camp counselor." And I went and interviewed and got the job, and I ended up doing that camp for 5 years.
Wow.
And but what that did was sort of steer me in the direction of children. And I knew that I was going to do something that was working with children.
Yeah.
And I, again, didn't know how that was going to be. It was like all these little pieces sort of falling into place. And then the final piece was I was also a hasher at a sorority. And I don't know if anyone knows what a hasher is, but basically we're the guys who prepare the food for the in-house women that live in the sorority. And there were many benefits as a young college student of meeting girls,
Yeah, no kidding.
having fun and getting food, which is always an important component of life. We got a little stipend, and it was like being part of their family. But one of the other hashers was a dental student, and he used to bring his projects in. And at that time, I really thought I was going into law, and I was involved in like the pre-law society, and my life plans were to go into law. And I started, I would ask a lot of questions, and he would show me his projects, and I would sometimes tinker around with them. And he could see I could work with my hands, and he just sort of, had made a casual suggestion, like, oh, have you ever thought about doing dentistry? Which at that time I was in my junior year in college. I was like, well, how is that going to happen? But he kind of explained how it did, and I went home and I kind of researched it and started telling people, hey, I might go to dental school, and they thought I was crazy. But people kind of took me more seriously when I actually got in. I got into every school I applied, including Harvard, which is the one I ended up going to. And then when I was there, I kind of knew that I wanted to work with kids. I wasn't sure how. And something I don't think you even know, Bob, is I don't know if you know that I'm actually dual trained as both a pediatric dentist and an orthodontist, kind of a rare combination. So when I did my residency, I finished Harvard and I came back for residency at UCLA. I did a dual program.
Wow.
So I with both of those.
So I did not know that. I know that Dr. Austin went on one of my medical teams. I can't remember which team it was. Which team was that, Paul?
It was in 2011. It was, I don't remember. We were in Sierra Leone. I remember the people who went.
Right. But do you remember where we went?
Well, we went to I was in Sierra Leone.
But which town did we go to in Sierra Leone? Don't worry about it. Okay.
I don't remember.
All right.
I don't remember. We were at a, I just remember the buildings with the green roofs and the sponge baths, and
okay,
we weren't far from so we had that new church that we had dedicated.
Okay.
And we actually had the clinic in there.
Okay.
You know what I'm talking about?
It may have been Lunsara, it may have been Kenema. It was.
I think it was Lunsara.
Lunsara. Okay, so Lunsara was the old copper mining area of Sierra Leone. Pretty tough place, by the way. So don't feel bad about not remembering all the places we go to, because I sometimes I can't remember either. So all the places we've been to over 25 years. But Paul, I want to back up a little bit. So you grew up in Del Mar. Now Del Mar, for those of you who are familiar with Southern California, there's a gigantic racetrack, a horse track there. Mm-hmm. Right? Am I correct about that?
Yeah, right in front of the ocean.
Yeah, that's right. And the Del Mar horse racing. And so I have a question. So how much of your time really did you spend at the racetrack betting on the ponies as opposed to jumping in the ocean? I mean, because you Del Mar people are committed to that racetrack, I know. Yeah,
it's funny you mentioned that. I obviously spent my life growing up on the beach. I know everything about the ocean. I can throw a frisbee, swim, body surf, whatever. Don't know anything about motorcycles, don't know how to camp, don't know anything about RVs, that's my life. But I did spend some time at the horses, and I actually got to be a pretty good handicapper. And when I would work jobs in the summer, some of the people that I worked with would actually give me money to bet for them on the picks I would have, and I was pretty successful. But I would do, I did a lot of analysis. I think I'm good at that kind of thing. So I would take the Racing Digest and a couple other forums that I would do. This is before internet stuff.
Sure. Yeah.
And and I would read up all about these horses, and I would look at the track conditions. I would talk to people who were local, and then I would go look at the horses and see, you look for certain traits in horses on shorter races versus longer races. And there's a lot of things that go into it. I mean, there's no guarantees, obviously, but I didn't do it. I mean, I did it more for the thrill of being right than I did, because I didn't bet a lot of money. I mean, I never made a lot of money. I never lost a lot of money because I didn't bet that much. But
right, yeah, you're a smart guy.
But I found it to be a fun kind of hobby, and people who did like betting enjoyed using my knowledge to try to help them. So
That's funny. Well, you are clearly more evolved than I was, because we had a Humboldt County Fair where I grew up, and I actually one year got a job at the horse track there. I was a gatekeeper. Okay, so I had to just make sure that everybody coming in was official. So clearly you were more evolved into the horse racing thing than I was. They kept me pretty far from the action, it turns out, out there by the gate. So Paul, that's interesting. So you ended up, so you were pretty deep into your college life before you made that major switch, and you had enough credits to actually get into dental school. That's amazing.
Well, I had to go. Well, so I didn't have a lot of the science classes that were required. And in fact, when I first got on that journey, I was thinking, well, wow, I've been taking all these classes in North Campus, and all of a sudden I've got to go to South Campus, which I don't know anything about. And I thought, well, we'll see how I do. And it turned out I did very well. And I thought, well, okay, I did that good. I'm going to take another one. And it turned out that my science GPA was almost perfect. I had a 3.9 something. I think I had one B plus in all the science classes I took. And so I think I was very motivated to do well. I was also, I think I overcompensated because I was always nervous that maybe I wasn't qualified to all of a sudden be in that side of campus. And but I had to extend my college to 5 years to finish.
Okay, that makes that makes more sense, because if you're heading, I mean, let's be honest, when you get into your track in college, you end up either being, a science kind of person or humanities, and law school tends toward being more of a humanities kind of major. So you made it. You got into a very good law school. You dropped the H-bomb there, by the way, where I'm told that dropping the H-bomb is something you have to do very carefully when you drop the Harvard name.
People say that, I don't know any other way to say where I went to school other than to say the name of it. But I'm kidding you. It wasn't law school, Bob. It was the medical school. But yeah, no, it was a great experience. I have no, that was a very hard program to go through. It was actually a 5-year program, and most programs are 4. So we actually did 2. We had to do 2 theses while we were there. But I mean, I would take after hours time with a guy who won a Nobel Prize. In fact, I asked him about it. He goes, "Oh yeah, it's here in my drawer somewhere." These guys were so humble and so brilliant, and I was just exposed to so many interesting people, and loved Boston. I loved all the history. That it was just a really kind of amazing experience.
Listen, I mean, going from Del Mar to Boston and going to Harvard has got to be a thrill, honestly. So good for you, Paul. I actually didn't know that about you either. So, okay, we're going to take I'm watching our time here. We're going to take a 1-minute break, friends. And we're going to come back to Dr. Austin. We haven't really talked about orthodontia yet, my friend. And so we want to get into that, and we will do that right when we get back. So friends, don't go away. You're tuned into the Hamilton Review, and we're coming back in 1 minute.
The Hamilton Review podcast is brought to you by Hamilton Babies, 9 kid-friendly products designed for the little loves in your life. Find them at hamiltonbabies.com or amazon.com. Also consider Dr. Hamilton's recently published book, 7 Secrets of the Newborn, available at Barnes & Noble, your local independent bookstore, and amazon.com.
So friends, welcome back to the Hamilton Review. We're continuing our conversation with Dr. Paul Austin. He's an orthodontist in Santa Monica. Paul, so you went to Harvard Dental School, but you ended up going into pediatrics and ultimately into orthodontia. So tell us a little bit about that end of the story.
So when you're in dental school, you're exposed to all the different specialties, and you have different experiences with all of them. And I was actually really good at endodontics, which is like root canals, but I just wasn't inspired by it. I was good at it, but it didn't really do anything for me. I knew I didn't want to be a general dentist. I think my biggest choice was whether to be an oral surgeon. I came from a school where the dean was the former head of the oral surgery program. They're just very influenced by oral surgery. In fact, all my letters of recommendation, all my research was all done in oral surgery.
Wow.
So
Okay.
I was headed down the oral surgery track. But I also spent a lot of time with the oral surgeons, and I thought, this wasn't the life that I wanted. And it wasn't, I wasn't working with the kind of population I wanted. And so that's kind of what steered me again back toward pediatrics and to orthodontics. Orthodontics, it's a little harder to get a grasp on it when you're in dental school. It's kind of a leap of faith. What I knew I was good at was problem solving. And I said, really, that's what ortho is. It's not a lot of hands. It's not using a hand piece. It's not doing a lot of stuff. It's a lot of problem solving and having a good eye for something and being able to analyze, again, data, just like when I was doing the horse racing. It's getting information and deciding what to do with it. And that's kind of what I do to this day. It's, you have a puzzle. Someone comes in and they have a bunch of problems, and it's, how do I get from that to what my desired outcome is? And that's what we do.
Yeah.
And the timing of that can be critical. And that's where, in pediatrics, there are some problems that are better addressed early. Some problems can wait. And I don't, do you want me to talk a little bit?
I was just going to ask you. So, okay. So when I think about, obviously we all get two sets of teeth. We get baby teeth, about 20 of them, which are called deciduous teeth, which means they, like a deciduous tree, the leaves fall off and the teeth fall out. The deciduous teeth fall out, all 20 of them ultimately, and they're replaced by 32 permanent teeth. So At what stage, Paul, do you begin to really engage patients?
It depends on what the reasons might be. So most parents can identify certain things that are obvious in their children. They can identify if the teeth are really crowded or their teeth are sticking out in some way. Some can even tell, cross bites. If they've gone in to have, it's really important. So, if they've gone in for their, say, first cleanings with their child, hopefully the pediatric dentist has identified, a cross bite that might be developing. So that can be different types of cross bites.
Yeah. Can I interrupt you and just have you explain what exactly a crossbite is? Because this is something that we hear all the time, but I'm not sure everyone could really define that.
Yeah. So we have different types of crossbites. We have what's called a posterior crossbite or a transverse crossbite, which has to do with your back teeth and whether they're wide enough compared to the lower arch. Again, the upper teeth should be wider than the lower arch so that the upper teeth stick out slightly over the lower arch. And then there's an anterior crossbite, which is like what a bulldog has, an underbite where their bottom teeth are in front of their upper teeth, which that's not the way it's supposed to be. Your upper teeth are supposed to be in front of your lower teeth. So those are two different problems. Sometimes they're connected. A lot of people that have anterior posterior problem, meaning a crossbite in the front where their bottom teeth are sticking out, they have an underdeveloped upper arch.
Yeah.
And that could be because of, a tongue problem, airway issues, speech. But their upper arch isn't developed. So sometimes in those cases, we have also a posterior crossbite. So they have an anterior crossbite and a posterior crossbite. In that case, we would put an expander and what's called a face mask to actually widen and advance that upper arch to try to get it back in front of the lower. And if we get them young enough, a lot of times we can avoid, surgery by doing that. And again, there's a lot of things you have to take into consideration, like what are the genetic, predispositions? Did mom and dad have that crossbite, or one of them have it? Or is this just kind of an anomaly? They grew and their bottom teeth kind of just shifted in front of their upper teeth, and now they postured forward. So there's different types of, corrections and timing for dealing with that.
Do you look at the parents when they come in with the kid? You actually examine the mom and dad?
Yeah. And that was hard during COVID because everybody was wearing masks. And so, it was hard to communicate. It was hard to see what was going on. I've had patients come in where the kid has a really bad bite. And the mom goes, I don't know why he has that bite. And I look at her and it's like, she has the exact same bite. It's like, like how they can't see that, I don't know. But I try as gently as possible to explain that there are some genetic components to that. And there could be other, components. And, but yeah, that the genetics definitely play a part in it.
Absolutely. So when you talk about young enough, you referred to when we get them young enough. What does young enough mean?
Well, in most cases with those types of crossbites, you want to get them as early as possible. And that usually is not earlier, although I have seen some cases where were so severe we had to do them earlier, but usually around 6 years old. So the first molar, they call them the 6-year molars. The first molars come in about age 6.
Yeah.
And they might have some lower front teeth as well coming in about that time. But what we want to do with those types of expanders we talked about is anchor them to those first molars. So if those molars are in, it makes it a lot easier. Again, if they're pretty severe, I might even put it on their primary or deciduous molars as well and do it even earlier. But those are somewhat rare. But usually if you can get them between 6 and 8, that's sort of the sweet spot for making these corrections easily. And again, when you're expanding, you have a what's called a mid-palatal suture up in the roof of your mouth. That begins to fuse later on in life. So the earlier you get that, the easier it is to correct, the less chance of relapse, and the less discomfort for your child. If you do that at age 7 or 8, and you turn that little expander, they're hardly going to feel anything, maybe a little pressure for 10 minutes. You do that to a 12-year-old, and they're going to be very uncomfortable. They're going to be miserable, and they're going to be irritable, as you know, teenagers can be anyway. But now they've got this thing in their mouth, they've got this extra pain. I mean, it's a big difference.
Sure.
And so again, and with a more chance of relapse the later we do it.
So when you're talking about expansion, you're talking about expansion of the palate. That's the palatine
expansion. Yes.
Right.
And then also when you're doing that, a lot of times, again, if we're going to do a face mask therapy where we're trying to bring the upper jaw forward, we're doing a slow expansion on the top while we're advancing it. So we're kind of freeing everything up, getting that whole jaw sort of moving.
Okay. I have a quick question. This is kind of a parenthetical question. Thumb sucking. People come into me all the time and say, my kid sucks his thumb all the time. And and typically I wink at that. I kind of go, okay, they're going to end, they're going to stop thumb sucking. Most people do. They get into elementary school and all the kids look at them and say, are you sucking your thumb? And then they pull it out and say, no, I wasn't sucking my thumb. Right. But your thoughts about thumb sucking?
Well, that can really devastate, their jaw growth. So we take it pretty seriously. My rule is 6 years. That's up till 6 years. The parent can do whatever they want to try to get them to quit. They can put something gross on their thumb. They can, I had a parent tell me they take the kid's dirty socks, put it on their hand, and then wrap it with duct tape so they can't take it off. So this filthy sock is on there that they won't stick in their mouth. Hey, whatever works. If it gets them to quit, that's great.
I think that's akin to child abuse, but anyway, that's right. in my mind. But anyway, keep going.
But we want them to quit definitely by the age of 6, because as that goes on, they are pulling that whole premaxillary segment out, and then the remodeling of that can take a long time. And then they're going to have to deal with, like you said, there's a lot of kids can be cruel as they get older, and they have to deal with a lot of psychosocial issues to do with that. And right. So getting that corrected, if you can get them to stop, a lot of times the body will return back to some of that on its own. But a lot of times I have to intervene and bring teeth back in or expand out their arch. They tend to create cross bites by doing that in the back. And it can also create a tongue thrust, because now you've created all this space and an open bite. And now you have a tongue thrust, which can also cause, speech issues.
Yep.
And so there's a lot of things that happen with that. So we try to do what we can to put an appliance in there, always telling them, look, this is not a punishment. We know how hard it is to quit. I tell the parents, I say, look, the reason they put their thumb in there is it's soothing. And when they rest that on their palate, it's akin to the nicotine in cigarettes. It's what keeps them addicted.
Sure.
And so what we try to do is put an appliance in there that blocks the addiction, blocks that resting motion. And then there's different versions of that appliance. We can make it more obnoxious or less obnoxious depending on how motivated the child is to quitting and what our success rate has been. So we have all kinds of stuff we do. I try to be as encouraging, again, never judgmental toward them. I don't want them to feel bad. I know how hard it is to quit. And so my job is really to be their, in their corner, be their cheerleader, and just encourage the parents, encourage the child, and try to get them to want to quit. Because if they want to quit, they will ultimately be able to do it. And our appliances are there to help them do that.
Yeah. No, I think that, listen, I don't see too many teenagers sucking their thumb. In fact, I see zero. Okay. So you talked in our pre-call conversation, you talked about the two phases that orthodontia usually takes. Can you walk us through that?
So the two phases is kind of what we've been talking about, the cross bites, the early problems. If someone has severe crowding, like they might have impacted teeth because there's not enough room for teeth to come in. Those are things that we will want to correct early on to, number one, prevent much more difficult problems in the future, and also prevent having to take out teeth. We in our office, we're very airway friendly. We don't want to take out teeth if we can avoid it. We don't want to constrict the arches. We want to have as much room for the tongue, for breathing. We don't want to create sleep apnea later on in life. And what we've seen through many articles is that, the 60s was a big, decade of when they took out teeth, even into the 70s. Even when I was starting, they were still pulling a lot of teeth. We almost never do it anymore. If we can get them young enough, again, to develop those arches, to create space, a lot of times we can avoid taking out teeth. And so that's what phase one is. It's usually, phase one means they still have baby teeth in, but we're doing something usually orthopedic to correct. If they just have a little crowding, that's not a phase one for me anyway. I don't do phase ones for that.
Yeah.
A thumb crib, again, they have the habit, they have a crossbite. Those are all early phase, phase one type treatments. Phase two just means you had phase one and now all your permanent teeth are in, and now you're having a second phase to, now the teeth that come in, maybe they didn't come in perfectly, maybe one is rotated, they want a final aesthetic result, or maybe we're still working on the bite a little bit. They had a pretty severe bite in the beginning. We corrected most of it. Now we're finishing it in the second phase, and that's when all the permanent teeth are in. And that's usually it. Some people who don't have need of that early phase will just have what we call single phase orthodontics. And that's usually, anywhere from 11 to 13 years old, typically, they just have one round of braces or aligners, and that's it.
So going back to teeth pulling, I hear frequently kids, going in to get their wisdom teeth pulled. Can
Yes.
you define wisdom teeth, number one? And do kids in general, is this what you're talking about in terms of teeth removal?
No, I'm talking about taking out premolars.
Okay.
So people would correct bites, would correct crowding, with pulling teeth. And there are still places around this country that do a lot of it. One of my assistants is from Alabama, and her daughter had her teeth taken out, and she said she worked for an orthodontist there that he takes out everybody's teeth. And she was so astounded when she came here and saw that we never take out teeth, and we do all these other things to preserve the dental arch. And she's a huge proponent now of what we do.
Keeping teeth. So what are wisdom teeth?
Well, wisdom teeth are third molars, and they are basically at this point unnecessary. Somewhere in the distant future, they will probably not even exist. They'll be sort of weeded out of the gene pool because they don't functionally have a purpose. So back when we ate a very coarse diet and people only lived to maybe 20, 30 years old, they would, you had your first molars, those would wear out, and then the second molars at 12 would come take their place, and they would wear out, and the third molars would come and take their place. But that obviously is not the case anymore, and we preserve our teeth. So the third molars really just, in most cases, there's not room for them to fit in the arch. And one of the ironic things that I notice is the people that come to see me that did have tooth extractions, a lot of those people have their third molars in, which
Wow.
leads you to believe, why did they have their premolars out if now they have room for their wisdom teeth. So it probably would have been fine not having any teeth taken out.
Do all wisdom teeth have to be pulled?
Not all. So it depends on the angle they're coming in, whether they're a threat to other teeth. I've seen teeth get ruined by an erupting tooth. What happens in a tooth that's erupting, a lot of times it has what's called an eruption cyst, and that cyst has the properties to help that tooth erupt into the mouth. Well, if left in a position that it can't come in and it's just left there for long periods of time, and it's approximating another tooth, it might resorb the roots or that other tooth. It could do damage. So a lot of people get them out to prevent that. And then the other issue is, if they're going to get them out, a lot of times we want to do it before the roots are too far developed. The one complication that you don't want to have in removing a third molar is damage to a nerve. Now, most of the technology today, we do a lot of 3D imaging. We have a 3D imaging here in our office, but they can identify where that nerve is and they're much more accurate about that these days. But still, there's no guarantee. When the longer the roots develop, the closer that root comes to approximating that inferior alveolar nerve. That's the one that gives you sensation to your lower lip. And if you damage that, you could have all kinds of problems. So people like to remove them before those roots get too far developed.
Gotcha. And that usually is age early teens, right?
Yeah, like 16 is typical.
Yeah. Okay. Mid-teens. Okay. Okay. So a couple questions, other questions I had for you were, more and more I'm seeing adults who are doing like Invisaligns or even getting braces. Your thoughts about that? And my impression is you say that, okay, let me just back up. When you mentioned to me that age 13 is kind of a critical age, especially for girls, in terms of trying to correct problems before that age. Tell us a little bit about the age, girls and boys, how they develop, and why age 13 is such a critical age.
Yeah, it all has to do with, growth potential. And so the reason that boys typically are taller than girls is not magic. It's just that their sutures remain open longer and growth potential is still available for longer. So they just continue to grow longer and they get taller. Girls typically by age 14, growth is done. Unless there's something unusual, that is, they're done growing. Now, you don't want to be trying to correct something that you need growth to help correct it, either on the downside of that, where they're fading out, or where there's no growth at all.
Yeah.
There's limitations on what we can do orthodontically. If someone has a large, let's say, overjet, where their upper teeth really stick out, and we're trying to remodel that or bring that lower jaw as far forward, having some growth potential gives us that ability. If we're only doing it orthodontically, that means just moving the teeth. There's limitations to how far we can do it. So there's going to be more compromise on the result if we have to do it that way. So we just get a better result if we have growth on our side.
So if before you actually reach, before the sutures are closed, in girls about 13, 14, and boys, you have a little bit longer, right?
Yeah, I mean, with girls, they really should be assessed by age 10 orthodontically, because if you're going to get started, you want to get that growth modification happening between 10 and 12, really, to get the maximum effect. And that's kind of a good time. But like 13, 14, they're on the downslope.
Saying? And boys, you would be saying?
Boys, you can go a little bit longer. Yeah, you can. Typically with boys, you can be 12 to 14 is not a problem. Boys just tend to grow, right up till, college.
Yeah. No, they do. I mean, I had my oldest son grew into college, and he ultimately got really tall. It's amazing. Yeah. He kept on growing. So people are doing these Invisaligns. They're doing braces. They're doing braces, alternative to braces, the metal braces. What are your thoughts about that? Is that in adults in particular, they have these progressive braces that they wear that are clear, and they essentially kind of move the teeth around. Is that something that really works? And is it permanent when you actually move them into a better place? Do they have to maintain those braces, that form, or tell us a little bit about that?
Okay. Well, yeah, what you're talking about are clear aligners, and there's a number of different companies that do that. First, you mentioned about adult orthodontics, and I would say adult orthodontics is probably the fastest growing aspect of what we do right now, because in the past, adults pretty much, didn't want to be involved in it because not many adults want to wear braces. And honestly, it's harder on adults. Their bone is more dense, their teeth move slower, their lips are, less compliant for having an appliance, and they are honestly bigger complainers, and rightfully so, wearing braces. Now, aligners kind of opened up a whole opportunity for people who were unhappy with the way their teeth looked to have something that was removable. They could eat what they want. They didn't have the aesthetic compromises. They didn't have, the discomfort. And honestly, the movement is pretty slow. I mean, each aligner is 0.25 millimeters of correction built into it. So you have a number of aligners depending on how many movements you have, and you change them. In our office, it's like every 10 days. We'll give you, say, 3 months worth at a time. So every 10 days, they'll switch to the next aligner and get that 0.25 millimeters of correction. And it does work. And I mean, the technology has advanced quite a bit since. I mean, I was in the very first certification class for Invisalign when it came out back in, I think it was 1999. So we've been doing it a long time, and longer than probably anybody in Los Angeles. And it has progressed quite a bit. I mean, in those early cases, I was having trouble getting minor corrections. Now we're doing, growth modification stuff. We're doing, really severe cases, expansion, even on adults. I mean, I've gotten some amazing results. But like anything, whether you're in braces or clear aligners, the hardest thing about braces, or the hardest thing about orthodontics, is not necessarily getting the result, it's keeping it. And that's where retainers are important. And so I always tell, especially parents, look, you're not just committing to treatment, you're committing to maintaining it. And maintaining it means being consistent for retainers indefinitely. And people need to understand that, because a lot of our patients that are 20 something or even 30 something were former ortho patients in their teens that didn't follow through with wearing their retainers. They're now back to get a recorrection, and they're doing clear aligners because it's nicer for them, but they're having to go through that treatment again.
Yeah. And retainers. Does everybody need a retainer? Does all your patients need retainers?
Ultimately, yes. I mean, anyone who's had correction definitely needs it. And I would advise someone, let's say someone comes in and they don't have, let's say they don't even have really any problems. I've had people come in who really have a nice bite, and they have maybe just a little bit of rotation here and there, but it's very aesthetic. They're happy with where their bite is. They're happy with their feeling. I say, look, you should still get retainers to keep yourself there, because as we age, we are shrinking. And those dental arches, which were straight at one point, if they lose even one little contact, that starts shrinking, and suddenly crowding starts showing. And now that crowding on the bottom, suddenly a tooth gets moved, and that bottom tooth now is putting pressure on an upper tooth. And now all of a sudden they come in, they go, this tooth has all of a sudden started moving. I don't know why. And then you look at their bottom arch, and you can see the bottom arch has been moving for years, and now it's putting pressure on the top. Yeah. So it's a good idea to have retainers, regardless of whether you had orthodontics or not, if you're happy with where your teeth are. If you're not, better just get your teeth straight.
How much do you have to wear retainers? You wear them at night?
I just have them wear it at night. So in the beginning, when they first get their braces off, I have them wear them after school or after work, and then to bed. And then at their first retainer check, if things are stable and they've been doing a good job, I just have them wear it to bed. And I find that routine works for most people, rather than just trying to force them to wear them all day long where they really don't want to and they resent it. And I've had good results doing it that way.
Yeah. Does every kid need to go to an orthodontist?
There are different cultural standards on that. There are different people's feelings on that. I'm an orthodontist. I have a very biased opinion. But I would say, look, if your child has a concern about their teeth, definitely, because there could be some psychosocial issues that, you're putting, that child could be at risk for if they're walking around afraid to smile or afraid to talk to people, and it could change the way they develop as a human being because of the way they feel about themselves. So I think it's important from that standpoint, obviously for keeping your teeth clean, not having periodontal problems, There's a whole myriad. And again, functionally how teeth are going to wear, the wear and tear on them if their bite is really off. There's a lot of reasons for having them, but that doesn't mean every child has all those problems. I do see a percentage of kids who parents say, look, does he absolutely need braces? And I said, I could say, honestly, no, they don't. I mean, just realize that these teeth have moved a little bit and you might need retainers to keep it from getting worse.
Yeah.
You
Very good. Well, listen, Paul, you're doing good work. I certainly appreciate what you do. And my patients who go to you love you, by the way, just FYI.
And vice versa.
And how do people find you, by the way?
Well, there's a lot of different ways. We are in the 1260 15th Street building. It's a tall building in Santa Monica. We're in Suite 812. But you can find us on the internet. You can look us up. We have Instagram, we have Facebook, we have all the social media stuff that everybody has. It's, Austin. That's all you got to do is type in Paul Austin, and you'll easily find a way to connect with us.
And how do you spell Austin?
Just like Austin, Texas. Austin.
Austin, Austin, with an I, not an E.
Yes.
Okay. Well, Dr. Paul Austin, you're a pleasure to talk to. Thank you for taking the time to be here. Friends, you have been tuned in today to the Hamilton Review, where kids and culture collide. We've had a great conversation with Paul Austin, orthodontist in Santa Monica, California. He has a great view of the world, by the way. I'm looking at his view here via Zoom. And I wish I had that view, Paul. It's pretty nice. So check him out. He's a good guy. So friends, until next time, be safe, be well, and we'll see you then. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.